I'm happy to call Marius Psychogios to present on behalf of Penumbra a lecture on meaningful innovation, science-based studies and devices. Marius.
Thank you, Vitor, and we will continue now from closing vessels to opening vessels, but stay on a tricky part, the distal vessels. And I will start with a flashback from last year, showing you all these very complex techniques for opening the very distal vessels. But those techniques were based on data we had from an older meta-analysis. And as you remember, this older meta-analysis shows that the reperfusion result is better with a combination technique, but surprisingly, the aspiration technique has a higher symptomatic hemorrhage rate. Right, so again, this was last year. This year we have data from the DISTAL study that was published a couple of months ago. Right now we also have data on not only the clinical outcome, which obviously was not relevantly different in the EVT group, you all know that, but also on the aspiration, on the stand retriever and the combination techniques. And as you can see here in the DISTAL trial, which by the way used older generation devices, so mainly the 3MAX and 4MAX were used, you can see here that the combination technique has better reperfusion results compared to aspiration only. And also regarding safety, we see that we have a reversal of this high symptomatic hemorrhage rate for the aspiration, but still all the techniques show that we have a high rate of symptomatic hemorrhage, as René has showed a couple of years ago in a monocenter study, and for the combination technique, higher rates of symptomatic hemorrhages. So what we have new since last summer, as we finished the trial, then we got, unfortunately, or fortunately, unfortunately for the trial, fortunately for the patients, the newer devices, and we have the RED 43 since finishing the trial. So the data that I'm showing you now is not from the DISTAL trial, but from a study we did with other centers after using the RED 43 for distal occlusions. And now you can see here with 85 cases, we have data that show that we have really high TK2B and 3 or even 2C and 3 compared to the aspiration group in the DISTAL trial or in the old meta-analysis. Again, these are retrospective data. We have to keep that in mind. This is different than a randomized trial, of course, but it shows that we are moving in the right direction with the newer devices. And also it shows that the safety profile is much, much better. As you can see, the symptomatic hemorrhage is now even lower with the RED 43 in our case series. So is it maybe for the DISTAL trial, some say that it was too soon, and we can see here in two large centers from the DISTAL trial that the TK results were really, really different. So you would say maybe we needed more training, and we are at the point right now for distal occlusions that we were in 2013 for the LVOs. So I will present you with three concepts that I found really, really important, and they are tricky, as we saw for the AVM treatment. It's tricky. I find distal occlusions are also tricky. So we have to keep in mind those three important concepts in my experience. The first is finding the face of the clot. And you would say, well, this is normal, right? We do this all the time with LVOs. Yes, you do this all the time with LVOs, but for DVOs or for distal occlusions, it's a bit different. Why? Because if you're injecting here from the carotid, you have contrast concentrated in the proximal carotid in the M1, but in order for it to go all the way to the clot that's in the A3 here, you have to wait, or you have to have a catheter near the occlusion, and that should be a bigger catheter. So again, if I show you the later series here, you will see, oh, maybe this is now the occlusion. No, it's not the occlusion. If you go and aspirate there, you will get nothing. You will just collapse the vessel. So initially, you will see here, there is a very, very big difference between the place that the actual clot was. So again, it's really important to be patient on your series and find the face of the clot. And I will show you in my presentation some examples from the DISTAL trial where actually things were not so good. So again, this was the last series in this first angiogram trying to find an M3 occlusion. you will not be able to find it, right? You will need a catheter that's placed more distally, and that catheter should not be a microcatheter, because first of all, you don't have a lot of contrast now that you can inject, and then having this angiograph here, I don't think it really helps. You will probably see something in the later stages of the microcatheter angiogram, but I'm not sure this was the clot in the end. And again, if you're using standard retrievers, that can be forgiving, but if you want to aspirate, you really have to find the face of the clot. Another example here with SCA occlusion, you will initially think this is the occlusion, but again, we are now taking a bigger catheter in the basilar, injecting and waiting so that we can actually see that even that is not the occlusion, even that is not the occlusion, but the occlusion is all the way there. So again, having the difference of aspirating there or aspirating at the clot is really, really important for your success. And this is the example in this specific case with the red 43. I think it shows nicely how nice you can actually go all the way to this small SCA without changing the anatomy. So also this catheter is softer, but you can aspirate nicely at the tip. And again, just a graphical example, what will happen if you don't reach the face of the clot? You will just collapse the vessel. And this has been also shown in previous papers in situ. So again, just to conclude here, the first part, you have to do a series from your guides, have long exposure, or take a bigger catheter near the clot and then try to find the face of the clot. Of course, you don't have to inject with all your force. We don't want to burst an aneurysm like Jan showed before. And of course, you don't aspirate before you reach the clot. You have to go and reach the face of the clot and then start your aspiration. This is an example where you can see we took the 43 all the way to the distal M1, then we did our series. You can nicely see here then the face of the clot, and then with one pass of aspiration we can actually nicely recanalize this vessel. The next point I want to make is that you have to measure your target vessel and choose the right catheter size. This is a point that I think not a lot of people are doing, but I think it's really, really important, and it is something that we now do all the time. Why? Because you're dealing with smaller vessels, and just taking your standard distal catheter is not the way to go. You should measure and tailor-made your treatments. And this goes back to the point of science-based aspiration, that the delta of pressure at your clot is going to be higher if you're not occlusive in the vessel you're treating. So actually you want around 0.8 of the vessel diameter for your catheter, and then the force on the clot is actually higher. And this is the part that helps you with better perfusion, obviously, but I think the safety part is also really, really important. Why? Because my idea after watching the older meta-analysis results with the high symptomatic rates of bleeding for aspiration was that people were taking stiffer catheters, bigger catheters, dissecting the vessels, maybe at the curve, and then also leading to a burst and big hemorrhage. And this is something that now we have seen in LVOs actually with large bore catheters. These are images from Heidelberg that Marcus gave me. And this is a really large bore catheter in this small M1. What can happen is that you actually can burst this vessel and have a big bleeding. And again, going back to the distal trial, another case that I think shows nicely why you have to measure those distal vessels and tailor your catheter on the vessel size. You can see here 1.4. The investigators here took a bigger catheter all the way to this vessel, and then you can also see how this changes the anatomy of this A1 segment. And what happened afterwards, after the pass, is that we see a big bleeding. And my last point is going quattro even with ADAPT. This is a concept I presented last year about having multiple catheters. And actually, I think this is really important because your big aspiration catheter here in the distal M1 is your embolic protection. And Raoul has published a paper on balloon guide for middle and distal occlusions and how it improves the reperfusion results. I think we will be able to show that this concept is even better because you're at the source of the bifurcation and then you can control your fragments. The numbers show this in our retrospective paper with the red 43, showing that we have higher first pass reperfusion results with the Quattro adapt technique. Again, going back to this ACA case, you can see on the perfusion you have a big deficit, you measure your vessels, you're going with your Quattro technique all the way to the clot, and then you're able to open this vessel after one pass. Showing a negative example from the distal trial, you will see here, this is initially the occlusion, right? It's an inferior trunk occlusion. You can see the clot nicely there. And then after some passes, what you actually have is a really bad result because you have opened the vessel here in the inferior trunk, but now there is an occlusion of the superior trunk and also part of the ACA. And that leads to a really bad example in this case, right? So is there a role of perfusion in distal occlusions? I think this is something that we are testing at the moment, we are analyzing at the moment, and may guide you through your procedures and decisions in the near future until we have the newer trials. So this is something that we are thinking that is important, that in the beginning you have to have a Tmax 6 of over 30-ish, maybe it's 40, maybe it's 50. We will have to analyze the data a little bit more and decide. But at the moment what we are seeing is that if you have the population that has an NIHSS of over 6 and a Tmax 6 of over 34, which is both the medians, you will actually see that there is a difference in clinical outcomes. And this is 1/5 of the trial. Of course, it was not powered for this, but still, it's maybe a hint that we should focus on this topic, on this patient group for distal occlusion thrombectomies. So to conclude, yes, we have to plan better studies and use dedicated devices. In our experience, the Red 43 is providing much better results. And we are planning the studies. We are now starting with Penumbra registry called the IRISE. That will collect those cases. And we are also planning distal too, so we will be able to show in the future that thrombectomy is still viable for distal occlusions. And I think teaching and training is really important. That's collaboration with SLICE, I think, is really nice to be able to teach the younger fellows those techniques, because they're not so easy as doing an LVO thrombectomy. I agree with you on that. Patient selection is going to be an important point, I think, in the future. And I think one point is we have to be faster also for those distal occlusions. One thing we will see, or we are seeing already, is that in distal and in ESCAPE MDVO, we were slower than for LVOs, right? But a really important point from ESCAPE MDVO is that in the first few minutes, actually, you see that the treatment effect is there for MDVOs. So maybe MDVOs are faster progressors than LVOs, but of course we have to analyze this and be able to show it. Thank you.